would go with these new teeth. It can easily scratch. You can easily damage the tooth with these ones. Hard to see. So let's talk about the OSCEs and the changes that came recently. So what I would be discussing about the cases that just came this week and last week. So the most recent one. So I'll just go through and I want to thank those candidates that shared their experience as well with us. So that would greatly benefit you all. So I'll share. So I'll go with the yellow. So the MIH combination set that came. So let me take it out. So the MIH combination set that's been coming. So there was quite a lot of changes in this set. And let me share my screen. So with the MIH combination set that's coming in the exam, I will take it out. Yeah. I'm sharing my screen. All right. So in this one, if you can see, there is, so the one that just came recently was about the aphthous ulcer, the prednisolone and actinol, the denture stomatitis, the 11-year-old with MIH crown fracture, and endoconsent. So these are the ones that came in the exam. And I think we were talking about the diabetes patient. So what they have done is in this crown broken at the gum level. So I'll just take out this case. This is what we've always been discussing. Yeah. So this is yellow set. And in the yellow set, we were talking about this case where you would have done the extraction, but halfway through the extraction, it got fractured. So now, in this case, they want to know, sorry, just let me take this out. It's quite annoying. All right, okay, so I'll just remove the waiting room. So in this case, now you've done the extraction, the crown broken, the break. Now what are you gonna do? It is still a Friday afternoon. You are 2 hours away. The patient lives 2 hours away. Now, what they have done in this case previously, it used to come with a facial swelling, which is still there. Of course, in this case, still, patient came with a swelling on the face. But what they've done is they've added diabetes in this case. And I think that's what everybody was talking about previously, that, and most of you thought that it was the diabetes case from the orange set, that they have shifted it to cluster 3. So I don't think so. It was that one. It was this case. This is the one they have. It's broken at the gum level. You've initiated the treatment. And now this patient is diabetic. And this patient was on metformin and she forgot to take her, it was given in the form that she sometimes forgets taking her medication. So in the exam, they're giving medical form for all cases. You will find medical chart, regardless, even if it's clear or not. You will find it for all stations on the table. And it's one page. And on the top, you'll find the patient's name, age. Some cases, the age was not given on the screen, but yet on the medical chart, you could see their age. And then the medical condition would have been ticked, yes or no. And right at the bottom, it's always been the same. The medical chart, I remember in my exam, it was similar. At the bottom, the names of the medications are given. So make sure when you scan it, you look at right at the bottom. And if you do find any new medication that you're not aware of, ask the examiner, ask them. So you've mentioned about this particular medication you're taking. Why are you taking this medication? Because some candidates didn't ask while others did. And it was quite helpful. I mean, not this case, but another one. So now in this case, it is a spreading odontogenic infection, and you have already attempted, and now it's broken at the gum level. And remember, it's the same case that we say the swelling is close to the eyes and it's not closing the eyes. And so patient, now what are you going to do? So in this case, of course, you have already initiated the extraction regardless. I would, same thing. It doesn't make any difference. I would still emphasize how important it is for us to remove this tooth even more, because patient's diabetes may or may not be stable. And we've already done a surgical procedure. We've already initiated. Patient is not regular, but took the medication today, took the meal today. And I would still explain to the patient about how we're going to remove it via sectional approach. And patient kept saying that, there's no dentist where I live. I live in a regional area. I've got 2 young kids. I can't even, we don't have any doctors or hospitals where I live. It's so hard to get to anywhere, especially having young kids. So which is why she didn't care much about her general health and her dental health as well. And same questions that they always ask is, can we leave it as it is? Now, I go back to the same script because I have the script from day one when ADC started the OSCEs 2018, and I can relate. This is 2018 script that they brought it back. Where I remember in 2018 as well, the examiners used to say that that I can't come back. I've got 2 young kids. And that information kind of disappeared along the way. And when I heard it back, I was like, oh, that's the old script coming back again. Now that's important. These are all barriers that you need to understand. And again, examiner was asking which antibiotic would you give. There was no allergies to anything as such. So I guess, it's, if patient doesn't remove, I will emphasize that I'll do it. But if a patient does not remove it with you, now in this case, hospital becomes very, very important for us. This is a patient that has uncontrolled diabetes, possibly, and you can't send them home with that infection. Either they do it with you or they go to the hospital. There's no other option for this patient. While previously, we were giving option by us, and we said if you want to go to the hospital, they might not see you on a priority basis. But now we say, yes, if you don't do it with us, you will be seen on a priority basis with that diabetes. All right. So that was this case, diabetes.
So, Dr. Nazia, did they mention that diabetes was not controlled?
Now, on the medical form, right next to metformin, now they're writing things, this case, and there was another dentist stomatitis in the same set in this case. In that case as well, it's in the medical form, it's written that they don't believe in taking medication, or she forgets taking the medication. Right? So in this case, it was mentioned she forgets taking it. And the reason she gave when she asked was, I have 2 young kids. I've got a very busy life. Now, those 2 young kids would be my motivation to motivate her. So I'll say, well, look, it's good to see that you're prioritizing you seem like to be a very, caring mom, and you're putting your health above everything else, your children above everything else. But imagine if you get sick, and if something happens to you, who's going to be raising those kids? What would happen to those kids? So I'm thinking about you. I'm thinking about them. So it's important we treat this tooth for you today, even though it's fractured, but it's still within my scope. I just need to explain to you how we're going to do it differently now. Same thing. But diabetes management, very important in preventive advice. And that's why it became a spreading infection. All right.
Dr. Nazia, can I ask one question regarding this? I just want to say that if the patient is having uncontrolled diabetes, then we possibly cannot put them through this stressful condition, right? Because we studied about the HHS. So now if we have uncontrolled diabetes here, we are going ahead with the extraction. I mean, I don't
Already
understand.
started the extraction. Now, there's a difference between this case and orange set. Now, in the orange set, you haven't started. You're taking consent, right? And where you have not started, you need to pick your battles, right? Now, in this case, they put you in a scenario, they say you've already initiated. And patient took medication today, patient took meal today, now you've already done it. And one of the root is broken below the gum line. You've already done that.
But Dr. Nazia, do you think that, I'm just asking that because they're giving us uncontrolled diabetes, do you think they want us to refer this patient to the hospital? Because even if we remove this tooth, there is a chance that the patient might develop delayed healing or infection or the HHS. So do you think, I mean, we should refer to the hospital because then we
That's what
want.
they want. That's what they want, that they to scare you. Now, we can't ignore the fact that this patient was saying, I have two young kids. And I'm talking about a real life situation. There was a patient that she had a severe headache. And I remember this patient came to my husband, and he did tell her, you need to go to the hospital. This is serious. Having that unusual headache, this is serious. But she said the same thing. She said, I've got two young kids and I don't want to go. And of course, there was nothing else he could have done that. But then the next day, unfortunately, the patient passed away. Now, here, you've already initiated, and it's within your scope, section removal, right? So now, and if you try to, and this is what happened, candidates were talking to this examiner. They said, well, why don't you go to the hospital? The moment she said diabetes, a lot of candidates, they kind of stepped back. They got scared. And they said, hospital, why don't you go? And that's what the examiner said. He said, there is no hospital where I live. And here is, well, if you send this patient to a hospital, the first thing they'll ask you, why are you sending this patient to us? When this patient has already taken their medications, their meal, I'm sure you would have you made that decision. That's the difference. Remember, this is not just random stuff. Where you have not initiated, make sure you do all the right thing by checking with their doctor, making sure that you have the approval before you do any sort of procedure that will injure the gums. But where it's already been initiated, they want you to finish the job. Don't walk away from it. Do you get what I mean?
I've got a
Dr.
doubt
Nazia,
here.
Yes.
So here,
actually, I
since
got this
we
case in the
have,
exam. I did.
Mm-hmm.
Dr.
So you got this
Okay, should I
diabetes version?
proceed? Okay, I got this case in the exam. No, I got it without diabetes, and I didn't give option of hospital. On the screen, actually, there was written that the specialist is away for 2 weeks. I just explained to the patient how important it is to be removed. I explained that it's totally under my scope. I can do it. We would just need to section it, and like they were okay. They were not opposing that.
Exactly. Even diabetes, it doesn't matter. I would still do it.
Yeah, the only thing is when I went to the giving the post-op instructions, we didn't have much time, and the examiner told me, "Look, doctor, you already told me all the post-op instructions before. Just tell me what is the most important thing I need to know." So at that time, I just told him like I will give him the antibiotics and he should use them. It's very important. And in case it gets worse, he should go to the immediate ER. And
Yes.
time was up. So do you
Yes.
think that was the most important
Yes.
thing,
That's
or
what
is
we
there?
call it as safety netting. This is safety netting in proper terminology, that you need to guide the patient when to seek help. Very important assessment area.
Okay, so thank you.
Dr. Nazia, another doubt. Since we have already started the procedure, so definitely diabetes must be okay. Then only we have started.
Exactly. So that's why I'm saying it doesn't make, if you've
Yeah.
started, that means you've done all the checks,
All the
you've
checks.
had the approval, but they're confusing you.
Yeah. So we have to explain and do it today itself by us if the
It's
patient.
even more important now to emphasize that I will even more emphasize that how important it is for me to remove this for you now. Okay?
Dr. Nazia, what antibiotic we should give here?
See, that we normally give. It's a spreading infection. Phenoxy with metro. You give phenoxy, to this patient.
Yeah.
That's it. I mean, you're doing active treatment.
So no need for metro, even if
No,
she's
no, metro
uncontrolled.
we don't.
Okay.
No, you're doing active treatment. And this patient, like, as usual, was asking, can I leave it as it is? Can you give me antibiotics? And when one of the girls, she said that I think there's two people that told me that the examiner, when she said that, look, there is a risk of infection developing, and the examiner was kind of arguing about it. Like, I already have infection. What else do you think? What other infection can develop? So she was like, no, it's a post-op instruction, which is another type of infection. This is why it's important we take precautions. And with diabetic patient, I would give them a call tomorrow as well to see and letting them know when to go to the hospital. So that's pretty much it. But please remove the tooth. You've already initiated. Don't leave this patient halfway. I would remove it.
So, Dr. Nazia, even though we remove the tooth and give him antibiotic today, so when is we say him to go to the hospital? Because I've already taken out the tooth.
Normally, what we do is you're taking a second consent here. So we say, like, now that you've broken, you have to tell them what happened, right?
Yeah.
So we say, now the tooth is broken, and I would like to discuss the options again with you, because now things are different. And I'm giving all the options. So the option is that removal by me, which is the preferred option. Or if you don't want me to do it, then hospital is the next best option for us today. But I would emphasize, I'll do it for you, right? And you will do it. Tell them how you're going to remove it. And also that check with them tomorrow, give them a call tomorrow to see how they're doing. But if at any point the condition is getting worse, they can always go to the hospital. Let them know what signs they should look out for. That's it. Okay, so hospital comes as an option today if the patient really doesn't want to do it with you, which I doubt. They don't want to go to the hospital, okay? But previously we were telling to the patient that, well, look, if you don't do it by me, the specialist appointment is next week or in 2 weeks. I'll give you antibiotics, but hospital may not see as a priority basis because it was immunocompetent patient. But now I'm skipping that specialist option. There's no need for specialist in this case. I cannot make this patient wait until next week. This patient will die. So either it's me, but if a patient doesn't want me, hospital can be an option, but this would be preferred.
Dr. Nazia, since he might not be very well controlled diabetic patient, should we add metronidazole to the antibiotic?
Look, we would go with TG. With this TG antibiotic is a very and TG says that you need to review them. If it did not respond in 48 hours to phenoxy, then you add metro. Metro is always now, according to new TG, as an add-on antibiotic. It's not a first line. If it did not respond, it should be added. Okay? So that's this case. So moving on to the next one. Then the next case that came was, of course, endo consent. I did ask that sulfur thing. So sulfite allergy. It was given on the medical chart. There was no other medical condition. And this patient scenario said patient had irreversible pulpitis with acute apical periodontitis. Patient had pain on biting in this case. And so probably it would be that necrobiosis stage. And one of the things that the examiner was asking that, but why are you doing a root canal? I mean, why can't you just simply fill the tooth? Why do we need it? So that's where we had to explain to the patient. So I think this question is just slightly phrased differently, but this is what they've always been looking for in this case. Like, what is going on with the tooth? Why are we going with root canal? So because the nerves have been affected, patient had pain on biting as well and sensitivity. And for everything, of course, patient was asking, why do I need to put a rubber dam? What will you do? And very interested. And then patient said that, look, I know there's some injections that my GP said that I could be allergic to and I shouldn't be taking those injections. So could you please tell me the name of anesthesia and the injection that you're going to be using so that I make sure you're giving me the right one? So that's how they asked, tell me the name for that injection. So now she gave Prilocaine with Valipressine, so examiner was quite happy with that. And yeah, sulfide allergy was there. And also examiner was same questions. They wanted to know why do you want to place a cap on the tooth? What do you mean by a cap? This is an old question they always ask. And same thing, the complications, like the perception that a lot of patients have in this case, they want to know is like, why do we need to place a cap? So one of the reasons, as we always say, that is it prevents the tooth from breaking, and also decay. Even if you do a root canal, these teeth could still potentially have decay. Oral hygiene is extremely important. Longevity of the tooth increases with a cap, and more importantly, sometimes it can discolor as well. So it will mask that as well. So I think in this case, main thing was patient was very interested to know which sort of anesthesia would you be giving to the patient. And even though if it's apical periodontitis, it doesn't matter. If you're doing an RCT today, the first stage, then you don't need to give any antibiotic. But if you're not, then you have to. Apical periodontitis, if you don't treat it, give antibiotic. If you're treating it, so now how would we make a decision whether I'm doing it or not? Look at the x-ray. Look at, is there anything in the coronal chamber that might impact your decision? Look at the radicular part. Is there something here that might impact your decision? Now she said that it wasn't as, it didn't look like this. So it looks straightforward. If you think you have good access, just tell them I'll take, I'll remove the DK, we'll have a look. And if I was able to see all the canals, sometimes this tooth might have 3 to 4 canals. If I was able to negotiate all of that, fine, we'll start remove the nerves. But if I couldn't, then one option is we can just temporize it on top, like pulpotomy you can do and refer, or to give antibiotic and refer. So now this conversation will really depend. They are changing the x-rays. So don't go with the mindset, oh, I can't absolutely do it, or I always have to do it. This is going to be a clinical decision in there. So that was for this endoconsent case. Then the prednisolone and actinol, that case has been changing a lot. Now they're starting to give photo in this one. They're giving pictures, which was never before. So I'm trying to get hold of that photo they're giving. So this is the goal set. So if I go back to this MIH, so the prednisolone and actinol case in this case. So the name is still Mrs. Zhao in the exam. And now they give a photo. And on that photo, they were talking about 3-6 was badly broken. And you could only see the roots, like literally the 3 roots separated from each other. 3-5 had a crown with the swollen gums around it, like you could see some puffy gums around it. And it looked like inflamed. And 3-7 had a crown, a PFM. And it wasn't looking great either. Now, what else have they added in this case? They've added a blood pressure medication in this case. So this patient was taking, so prednisolone has always been there. Arthritis, actinol is always there. Patient was taking Panadol Osteo for arthritis. But patient said it is also helping me with dental pain. But more importantly, there is now antihypertensive medications they've added. Patient was a 73-year-old old man, and clearly, and patient smokes. Smoking is one of the reasons for that hypertension. Smoking causes blood pressure. And patient also, what they've added in this case is very interesting. Facial swelling. This never came with facial swelling, ever. So the version that used to come in the exam was these ones. Irreversible pulpitis, or localized infection around the tooth, or wobbly tooth, or maybe just a bone pain. But now they've added facial swelling as well. In this case, patient had it for 3 days, and patient said, I feel like this swelling is not going down. It's not going away. So I just wanted to know, what you can do about it. And of course, you can't treat this patient today. Patient was on prednisolone. You need dose adjustment for that. And we can't extract the tooth either or do an RCT for that. You will end up giving antibiotic in this case, which is what this patient was very interested to know. Which antibiotic would you give? And we will be giving this patient phenoxymethyl and metro. No allergies was there. So now, because there's going to be 24-hour delay, so we have to give phenoxy with metro in this case. And this patient was very interesting, said that I don't believe in using machines. Machines are not good. This is why I don't check my blood pressure. And even my GP said doesn't check it much, and he just gave me medications, and I'm just been taking medications. And patient wanted to know, and of course, patient had seen a dentist a few years ago, and was told by the dentist as well about a gum disease and how gum disease could impact this abdominal that the patient just started back then. And if there was any procedure, it might impact the wounds. And then the patient was asking, is this what you're also saying? Is that what the dentist was referring to? So, yeah, so just the new addition in this case was antihypertensive medications and facial swelling, which is very interesting.
Hello, Dr. Nazia.
Yeah.
Patient was having Actonel only for 3 years, so that doesn't make a high risk according to the TG. But again, he was having prednisolone for 10 years, so that's definitely another risk factor that make him on high risk. Yeah.
Yeah. That's it. So that's prednisolone was, and concurrent medications when they're taking. It's still the same. It's still the same. Nothing changes the way we used to discuss.
Yeah.
It's just adding another layer of why you don't want to do it, right? It's still a stage 0.
And still, we will refer to the specialist, considering the Mroj could be sitting there already.
Yeah.
Okay.
Launch could be there.
So we'll give antibiotic today, and then we'll say we'll be referring to specialist, and the specialist will liaise with the GP regarding the dose adjustment thing, right?
Yeah. So main thing here is, remember, they want to know why are we referring to a specialist, because you can do it. The main issue is medical legal here, because stage 0 is something that we cannot see through our conventional x-rays. And if a mirage does happen, patient can easily come back and sue you for this. And the only way to be able to tell if it's there or not is by doing a CT scan, which is done by a specialist, not us. All right, so that's where the problem comes. So with CT scan, look at this. This is also a mirage stage 0, and this is on a CT scan. It shows clearly. And this patient having a pre-existing mirage was basically because of that gum disease. They're clearly saying, I have gum disease.
Nadia, so how in teaching now they teach us how to, treat Mroj if it happens. So in cases where the Mroj is already there, is there a way like the specialist will be doing it in a way that, or he can manage it in different way, or is the management will be same?
In this case, specialists will remove it atraumatically.
Yeah.
Right? Because it was literally broken at the gum. So that's another reason.
Yeah.
But the first reason is medical legal.
Okay.
Right?
Yeah.
Because see, if a patient has an awareness that it's already a stage 0, whether you remove a switch doesn't matter. We know that it's neither your response. When things go wrong, and we've all seen it in our life, when things are good, everybody's happy, everybody's your buddy. It's only when things go wrong, then you see who was on your side and who was against you. Right? So this medical legal is a big issue here.
Nazia, according to my understanding to the TJ, I will explain it to you, and you should tell me like if it's acceptable or not. I'm not sure, but in TG, even if it's stage 0, we don't initiate, but we can take advice from the specialist. So I will tell the patient, it depends on the case. If the tooth is wobbly and I feel that me or the specialist can remove the tooth the same way, I will tell the patient, I will take advice. I'm suspecting there's melange. I will take advice from the specialist. If they allow me, I will remove it and I will start treating melange immediately. But if I feel like the specialist will do it in a better way, I will explain to the patient, like this tooth is badly broken. I need to remove the roots. I will explain that I might be more I can make more trauma to the bone here, so I would refer you to the specialist. So should we tackle it according to the situation, or if you
Say
are
that.
suspecting stage 0, we always refer?
See, again, recommendation differs. So remember we always used to say, look, if you want me, I'm happy to take advice, but I would recommend, seeing a specialist for this, right? So the recommendation would come. So now let's say the specialist is busy or the cost becomes an issue. And if you are supported by a specialist, then you should be able to do it, right? But
That's
you still
correct.
need to give your recommendation. And the whole
If the
points
tooth
are
is
around
wobbly, I
recommendation.
will do it after advice. But if it's not wobbly, I
Oh,
will
this
not
was
do it.
broken. This was like 3 roots. This always, the prednisolone actinal case comes as a surgical extraction, always.
In this case, I will not do it.
Yeah, it's like this. If I show you an X-ray, they are giving you now 3 roots broken at the gum level.
Yeah.
That's not easy to
I'm just
do.
discussing the basics, how it should be done in case they changed anything. So,
Yeah.
Dr. Nazia, if I see that the tooth is wobbly and me and the specialist can remove it the same way, but it's
Yes.
stage 0, can I tell the patient I will take advice because the specialist or me, we will remove the tooth the same way? It's wobbly, it will remove easily. And regarding stage 0, I might start treating it under the advice of the specialist.
Absolutely. See, there's 2 problems. One was medical legal CBCT, which a specialist can do it for you, no problem, right? 2 was looking at the tooth clinically, right? So wobbly, easy. You can do it. Specialist guiding you, patient understands, everything's good. Yes, fine. But if it's badly broken, surgical, and majority of them are surgical in the exam.
Yeah. Okay. Thank you so
Surgical,
much.
we have to be very careful with those ones.
But Dr. Nazia, the denosumab that is wobbly. So what about that? So in that, can we follow Dr. Mohammed like logic? Like if it is wobbly and I take specialist advice, and as long as you are informed that it is stage 0, and you sign the informed consent, we can do.
In this case as well, if you see, we were saying that I can do it as well, or specialist, but I need an approval of the right. You need that. But today you couldn't do it for this
Yeah,
patient,
yeah,
remember?
yeah. For this one, yeah, for sure.
Yes. So if you see in my flow chart, I always had this. Do you see specialist advice?
Yes, yes.
It's always been there. So because from a tooth procedure perspective, it is within your domain. It's easy. I mean, to remove it, not a big deal. But medical legally, I need that CBCT, just to make sure this patient does not come after you, later on. Okay. So that's fair. So the cases are, if you look at it, still the same. The core never changes. They are just tweaking things here and there a bit. So this is why it's so important we're thorough with the main idea. What is the main idea? So prednisolone and actinol case, everything revolves around melange, things that causes melange, patient being on prednisolone for 10 years, 5 years, and the things that caused perio. The things that caused perio was number 1 was patient's oral hygiene was bad. Patient was a smoker. Arthritis causes periodontitis as well. All right, so it causes inflammation of the joints, it causes inflammation of the gums. And prednisolone, also low immunity, increases the risk of gum disease. So if somebody has a gum disease and they are on this medication, perio infection and being on Actonel, Ronch could already be initiated. It already potentially could be there. So that's where we're going. We're doing two types of risk evaluation. We say that the things that put you at higher risk or the things that might have already initiated this process for you. So we're not sure. And that's why I need a specialist on board with me to do the scans. Two, this is not going to come out easy. It's going to be traumatic extraction. So, my recommendation is specialist. Done. But smoking is very important. And you need to tell the patient. Now, smoking caused hypertension in this case. Oh, hypertensive medication. Let's add another one. Now, that is basically adding dry mouth. And hypertension was a sequelae of smoking. Right? So that's a bit. So it's the health promo is around smoking in this case. Being regular, clean your teeth, quit smoking. That's the health promo.
Dr.
And-
Nazia, I have a question regarding this
Sure.
case. It was mentioned in the case that the pain is coming from 3-7, and you also mentioned that now they are giving a picture at 3-5 and 3-6. They don't look too good as well. So are they still mentioning the pain is coming from 3-7, or we have to ask
No,
questions
3-6.
to
Now
like?
they've moved it to 3-6.
All right. Okay.
3-7 has a crown that looks really bad, and 3-5 had swollen gums around it, like you could see perio.
Okay.
Overall, his mouth was
Dr.
crapping, right?
Nazia,
Yeah.
it was 3-5, 3-6, and 3-7, and 3-6 was gum level grossly carious with some plaque. You can see like it was like that. And I actually forgot to talk about perio, and I couldn't really see. According to that picture, it was nice, healthy pink gums, like not anything periodontitis kind of. And it was picture from top view, like a closely taken clinical picture. Also, there was Panadol osteo in the medical chart as well.
Yeah. So there was 4. Do you remember the name of that antihypertensive drug they was taking?
Like the sartan categories at the end, sartan.
I
Yeah,
think
there was
Dr.
not.
is
Yeah, I
Arbisatan.
don't remember exactly. Yeah,
Albisatin, right?
yeah,
Albi-
yeah. Not V, A with A starting with A and sartan at the end.
Yeah, that's the medication. Oh.
Yeah, that was LB sartan. I was trying to see in the memes, but I couldn't really check, and time was so short, case was so long to read, and then chart separately to read. So it wasn't enough time to see all of those things. So I just left it, and I just asked him, and he was nice enough to talk about that. Oh, this medication is for hypertension that I'm taking.
Yeah, so it was
And also he was not motivated at all for quitting. Like he said, like he didn't literally went to that. So just leave it, please. Can you take this tooth out for me? He just straight away went to that.
So, but do you see that smoking is so important in this case? Always been.
Yeah, yeah.
That's this smoking is one thing they want us to talk about extensively in this case. So I think it was this medication, right? Was it this Abisartan? Or was it A? Something with A.
Not RB sartan, LB sartan.
Albisartan. Okay, I'll check with that. But we know that most of these medications they cause dry mouth, and that's the conclusion. I would have asked this. Did you guys ask like when was this patient diagnosed with blood pressure?
No.
I just ask all these questions all the time.
But
Okay.
I think he already mentioned that I'm taking this medication for a few years, like long ago. It's been a while.
And this patient
it
did
was
say that
too
I don't
much.
believe.
Yeah, it was too much to go through in short time. So main focus was on ectonail and other stuff, but not on that. Yeah.
Yeah.
Like in my
And-
head, it was there that I will talk about dry mouth that these medication can cause, but the more talk was about taking the tooth out, so I didn't went to here and there. Just why he's here today.
Yeah. So the main focus is still two things: perio and ronge. This is the two things. And whatever they're adding, they're just adding on to this list, nothing more. Right? All the things that causes ronge, all the things that causes perio, both are the same. very similar to each other, right? So the things that increase the risk of bronchitis, like 3 years is still comparatively low risk, but there were additional risk factors in that case where there was the mandible, patient was smoking, patient was concurrently taking prednisolone, and then on top of that, traumatic tooth removal would all increase the risk on a higher level, and having a gum disease or infection means it could be a stage 0 already. Duration and gum disease or infection. So these two. And then we talk about, so this is why it was important to talk to this patient. What are the things that the patient needs to stop to make sure that the gum disease settles? And smoking has got a lot of effects. Smoking causes hypertension. Even for rheumatoid arthritis treatment, the medications that they take. Now, this patient, think about it. This patient's taking prednisolone for almost 7 to 10 years. Nobody takes steroids for this long. And if it's not working, that means this is not stable. And why is it not stable? It's because of smoking. Smoking really impacts the medication for arthritis. That's why the arthritis medications are not working, and this steroids is wrecking his body. So it's just all about making connections and telling the patient that this is the culprit. Let's fix these two. All right, smoking and being regular solves all the problem. But this patient was not motivated.
Excuse me, may I have a question?
Dr. Nazia, you're talking, this
So-
case is about perio and mronge. So how are we going to talk about perio in this case? I don't feel like we will have the time, since we are discussing with patient about removing the tooth, about mronge.
This
Should
is
we
so
just add it?
important.
Should we add it to the risk factors of, like, because of perio or infection that you might have more risk of mronge, or we need to talk about perio as a separate issue?
See, if I were to make a flow chart for this one, I would just put it like this. If you look at technically, this case is built on two things. One is high risk, and the other one is month, right? No, sorry, straight 0. Where is my pen? Where is my pen? So now this patient already has, so high risk, you all are talking about it. But if it says stage 0, you have to prove that theory, right? They're interested. So I've got my pen here now. Let me MS Paint. Okay. So I'm just going to write it down. So how you should be going about. So your conversation starts with Mranj discussion for sure. So it all goes under the discussion of Mranj. So we talk about Mranj two ways. Either it's high risk, right? So we now talk about it very differently, or it's a stage 0. So high risk, as you mentioned about it. Why is it high risk? Because of the medication actinol duration. We all know that. So now there's two drugs. One was this, and the other one was prednisolone. These two together will damage the bone. Then what are the other things that could affect patient-related factors? So also the mandible, age, smoking, right? All of these will again reduce the further blood supply. Then procedure-related risk factors. It was going to be a surgical traumatic extraction. So all of these put you at a very, very high risk. Now, what we're also concerned about is, what if you're already on this condition? What if it's already there? Why am I saying that? Is because you were already on actinol for 4 years or 5 years, whatever it is. Plus, you had a gum disease or infection. Like I said, it comes in the exam. Now, those are the things that might have already initiated. Now, what caused that gum disease in your case? It's because you haven't been regular with your dentist. Plus, your oral hygiene wasn't the best. Plus, did you know that, with arthritis, rheumatoid arthritis, and smoking, these are the two are directly linked, plus the medications, hypertension medications you're taking, all are linked to perio as well. So what do? Let's bring your risk down. Do you see what I mean?
Dr.
Connected.
Nazia,
Yes.
I didn't talk about periodontitis at all because from the picture I couldn't see. Like, of course, he's having few risk factors, But is it necessary that we should have talked about that you are having, because it was nothing like that?
Oh, no, but the patient, if you would have asked about gum disease, patient would have mentioned that to you, right? That I have a gum disease and my dentist told me about it.
Excuse me, may I ask a question? What
Sure.
was the bold part there? Fariha has in
Yes,
the
Faria,
exam.
what was the
So
ball part?
To be honest, at that time you don't even remember anything when you come out. I don't recall anything.
so is it written that you
Like the
already
investigation.
examined, or
Yeah, like, I remember it was more about investigation, what would you do, and patient concerns, kind of like that.
Yeah, it's like
But
this,
it was
right?
longer than that. Yeah, it was longer than that, but nothing is special. In other cases, they other case had you don't have to mention definitive diagnosis. That was um sorry, I'm not good with the memory. I will unmute myself again and will let you know.
No,
You can
that's
continue.
okay.
But yeah.
No, thanks for sharing that. So, in this case, that's what I'm saying. So the entire assessment is in this area. This. What you guys are talking about, this is what we call it obvious. This is very obvious. Everybody knows, everybody talks about, right? And this area, we're talking about critical thinking. And that's where the problem is. This is where medical legal are coming. Okay. So very important. And that when you say perio, then you have to prove why would this patient have perio? Because around this area is where your preventive advice comes. This is your preventive advice. And smoking is a big part of it. Smoking is causing arthritis. The medications are not working. Smoking led to hypertension. Okay. Smoking and the gum disease, like poor oral hygiene, led to gum disease. Smoking causes melange. So this is the problem area in this case. All right. So I'll go to the next one. Denture stomatitis case was the same. Yeah, there was no changes in this one. I think it was still the same patient on blood pressure. Diabetes wasn't very regular with his medication. So yeah, picture was the same. So this is same. I think the other one that changed a lot was Aptus ulcer. Yeah, Aptus ulcer as well. So this is this case Aptus in the red set. Where is that?
Nadia,
Yeah.
can I ask for denture stomatitis case? Usually, if the patient is having uncontrolled diabetes, do we straight away refer to oral medicine, or can we find out the factors and solve the factors first?
No, you manage it yourself. You don't refer.
Oh, okay. All right. All right. So we'll reline the denture and give denture hygiene before review after 1 month and give the antifungal like normal.
So we don't, it's nothing changes, but it makes it even more important for us to send this patient for a medical check and emphasize that how diabetes leads to fungal infection, right? This fungal infection is part of that. And that's the whole idea of giving this patient a denture, especially in the lower jaw, because see, what the patient eats will affect his diabetes. And it will affect. So this patient doesn't want a lower denture. So we have to get this patient to wear. And when you give a preventive advice, same thing. We always say from three perspectives. One, it is from a general health perspective that your diabetes will affect your oral health. Your oral health will affect your diabetes. So they're both connected to each other. They're not two different things. So from my end, I would recommend being more regular with your denture checks. Also going ahead with the lower denture. It's important. Back teeth are meant for chewing, not the front teeth. And that's how we can prevent combination syndrome or getting it worse. And then from a general health, I would like to get in touch with your GP. We need to check on your diabetes because this patient said the same thing. I don't believe on those machines. I don't believe in machines or using any of those machines at all. So there was a belief issue. And I think for what ADC is testing, what they're checking is like I keep going back. These OSCEs are not just they're going to the examiner, showing how much I know or information. It's not about that. It's about who you are as a person. Can you read between the lines? And if a patient comes back with any sort of barriers, are you able to identify the barriers for this patient? Because without that, you cannot provide them any treatment. So I think this is what we talk about is problem-oriented method of diagnosis and treatment, which is a discussion with the patient usually will happen about what the problems are, and then the prioritization of the problem list. So for this patient, even if it's dentist stomatitis, prioritization of problem is I can realign it at least so that it's not only comfortable for the patient to wear it, and it's also not injuring, but at the same time, it's a temporary solution. So we have to think long term, and then you go step by step with that. So that's the kind of approach they like to see in you
I
guys.
see. Because I was thinking, because this patient is having uncontrolled diabetes, so do we need to bring in any systemic antifungal for this patient?
New TG says no.
Okay, all right. Thanks for clarifying.
Yeah, no. We were doing it, but I love this line, which I'm sure you would have seen it previously. This line is very important, which we don't do that in the OSCEs. When I say that, these OSCEs are all built on health promotion, all cases. So they pick a health promotion, they build a case on top of it. Now, I can see it because, again, like I said, my biggest strength is pattern recognition, and I can see what they're doing and why they're bringing it. Because if we're not prioritizing the health promotion, we're paralyzing these patients. These patients are getting dependent on us. Now, what long-term leadership looks like, it says involving the patient in decision making. And at the end of the day, it places the responsibility where it belongs, is the patient. If it's unmotivated patient, I'm going to scare them, right? So logic wouldn't work. I'll scare them. But there's something that they love. What is holding them? Find that weakness. So, like I said, in that crown broken at the gum level, she wasn't caring for herself because of her kids. I mean, it's fine. I mean, it's good to see that she's loving her kids, but at the same time, she can't compromise her health. If she's not there, who's going to be looking after those kids? So what am I doing? I'm not owning that problem. This is her problem. The problem, after all, belongs to the patient, not the doctor. So a patient who owns the problem and recognizes is the one that is likely to cooperate. But what are we doing? We're spoon feeding. We're doing everything for the patient. That's why these patients are not taking, you guys seriously in the exam. They're just saying on your face, no, I won't do it. Like, please do it. No, I won't do it. Well, if they don't do it, tell them the consequence. What will happen? It's fine. I say, look, I respect your decision if you don't want to go ahead with the treatment, but I want you to know what will happen from here onwards. This is what's going to happen to this. So from that way, patient will own, but don't give solutions. You're not supposed to give solutions. Your job is to work with the patient because they would be able to tell you. Like, for example, in diabetes cases, patients, if they're saying, I don't believe in machines, I don't check it with machines. So I'll say, well, what is something that you don't believe about it? Right? This is important area. This is extremely important point. Now, what happens in the OSCEs? We're like, oh, the examiner is wasting my time. No. This is the assessment area. Because if the patient does not believe in that, how do you think they're going to comply with the new denture they're going to wear? They don't believe in you either. Simple. So you need to question that belief system. I'll say, all right, so what is something that you don't believe about the machines, if I may ask? Patient says, well, they might always show you wrong numbers. They might always show you higher numbers, so I don't use it. I say, well, look, well, it's a good point you've raised, but These machines will only show you a high number if it's really not stable, it's not under control. If you take your medications regularly, why would it even show you a high number? Just leave that question there, move on, and then towards the end, let them know what diabetes does to the body. So we say, like, see, now I know you're not really looking after your diabetes really well, but if you can see this fungal infection, we call it as a disease of the disease. It's an opportunist infection. So when your immune system goes down, this is the first thing we see. And imagine if inside your mouth it's causing so much harm, think about it. What is it doing to your body? So do you think we could bring some change? Could you think moving forward we could do something about it? So with those questions, give them brochures done. The examiners will say, yes, you know the strategy. This is it's a pass from their end. No prescriptive
Dr.
style.
Nazia, I have
Yeah.
a question regarding the apical third root fractured in the red set.
Mhm.
Are we going to try to remove it one more time after taking another consent from the patient, or we are directly preferring to refer this patient?
Depends on which route it is. Never go with that, black and white, yes or no answer in that. There's 3 routes. Palatal? No. Mesial distal? Yes. Think about the anatomy, structures around the tooth, right?
So if it is
Palatal,
palatal,
straight.
yep. So we are not even going to try, because we normally what we do is we say that we are going to take another X-ray, and we will also. It's I think also mentioned in the scenario that we have cleaned it and we can we will see it in the light. So I was just confused, like you said that most of the time they want us to do the procedure, but in this one, should we say that we will try it one time, but then there is now a higher risk of developing the OAC, and with the bone removal there will be more bleeding. So is it worth mentioning this thing, or we just prefer to refer this one?
Now, along that note, you said that the examiners always like us to do something. It really depends on the case. Let's not generalize it, because your first domain, it talks about professionalism, right? And this point number 7, this is always assessed across all cases. It says recognize your own ability and competency, right? Very important. Now, this apical 1/3 comes in different versions. So if it's a palatal version, if it's a palatal root broken, yes, we were saying that I'll use my suction, because you've luxated the tooth, so we don't know if that little root fragment was luxated or not. So I'll use my suction. If it comes out with my suction, done, you're good. But now, if it doesn't come out with your suction, that means that root fragment is not even luxated. Now, the only way to retrieve it is you have to stick an instrument inside it. And knowing the anatomy, this is the one that is closest to the sinus. Don't do it. This is where, if I say yes, I'm showing the examiner I am overstepping. I'm not a safe dentist, disregarding the anatomy. But if it's a mesial or distal root, yes, we could give it a go, because anatomically as well, mesial and distal root are different. They are not always sitting inside the sinus. Okay? So root, look at the root.
Okay, thank you.
Dr. Nazia, what if the palatal root is fractured at the gum level instead? It's not the apical part.
See, the core never changes.
Okay.
Even these new cases I'm saying, the core is still the same. The assessment areas will not change ever, right? Unless they come up with a completely new case. Because we already have crown broken at the gum level. Right. And they left you 3 roots there. Now, what I'm saying is this is mesial and distal root. Mesial and distal root are not sitting inside the sinus usually. But the palatal root position is like that. It's basically right underneath is the sinus. So you have to be very careful with that. That's what they're assessing in that case. Okay, so no, I wouldn't. The palatal root, don't stick any instrument inside it. So after sulcer, so this was a 19-year-old girl, and it was on the cheek. Now, yes, I did confirm they don't have any celiac in this. in the medical chart or in the family, there was none. There was no tummy issues as such. But what was interesting was that patient recently quit smoking about a year ago, and was a lot of stress. So quitting smoking and stress was the two main triggers, and the third one was diet. I mean, even though patient said I eat healthy, but of course, because of the exam, because of the workload, so and patient was asking which nutritions we need to get checked, what we need to check, and what else was here? Patient said, I'm very stressed because I've got an exam and couldn't eat spicy food. And was asking, how would you differentiate traumatic ulcer from aphthous ulcer clinically? How would you see it? How would you differentiate it? And what else was here? Yeah, but main thing here, celiac is not here, but stress is there. Remember in this case, I always used to say stress and celiac, if they've removed celiac, stress is still there. And there is no cure
Nazia,
for
with
aphthous.
this ulcer case, are we adding oral syphilis as a DD? Because in the new TG it mentions always consider oral syphilis.
Syphilis, if you want to add it, but it's a bit tricky in a sense if you want to talk about it. And I think in DD as well, it says, was it the first line or the second line? It was for persistent ulcer, right?
So I had this case actually, and when new TG wasn't introduced, I was in period 1. So I passed the case, but I clearly remember when I was finishing up the case and all the history questions and everything was indicating that it is an aphthous ulcer. But obviously, it was clearly mentioned that you have to mention DDs. So I did mention all the DDs, but I didn't mention syphilis. When there was 5 seconds left, the examiner asked, like in a very low voice, as if he was a bit embarrassed, and he said, "Do you think, doctor, it could be something related to?" I couldn't hear the last word but it seemed like he was pointing towards sexually transmitted disease. But I just said, look, by the signs of it could be, but let's see you after a week and then we can further investigate. So I don't know. And now in the new TG, it says that mention oral syphilis as well. So
yeah, so see again, if I go back to 2018 script, which is resurfacing again, so one of the things I would check with her, there was the colleague had viral ulcer, viral infection. And that's what they used to ask. Do you think, is this viral? My colleague had a cold sore, or, herpetic, we talked about, right? Herpes labialis kind of thing. It happens inside the mouth as well. So and then there was another version where the examiner said, I stay in accommodation, we share plates. Do you think I might have caught it? My sister had syphilis. Do you think I might have caught it from her? So the perception was around those areas. So I don't know if they're bringing that back in, but I will first rule out viral because viral does happen inside the mouth as well. Yeah, I mean, it can be. Because if it's syphilis, they need to be referred. But this is usually they say it's more persistent. It's not the first line kind of thing we would suspect. I think it was given an ulcer here somewhere. So if I go back here, so do you see the most commonest cause that we talk about in this case is aphthous and traumatic. These are the two most common. Now in the infectious one is where bacterial we've got, you see? I know it for sure in the exam, they used to ask about herpes in this case. And this is also, again, a sexually transmitted like type 2. Type 1 and type 2 is different. And then this is another one.
So when they ask us about that, what should we say? Regarding the herpes one, that do you think it is that?
So I'll say like, well, what do you think? Remember I always say, always check with them their ideas. I would always check with them. I'd say, all right, so what do you think? Now patients, I know her patient's name. So her name was Bennett. Finally, I got to know the name. So it just gives you a peace of mind when I know the exact name. So Bennett. So Bennett was, I would ask her, so Bennett, do you have any idea what might be causing this? So if she says, then you can give a classification. I would say to the patient, I'll say, look, Bennett, now there could be a couple of causes for that. Now there could be most common causes, and sometimes it could be related to infection, or sometimes it could be related to many other, related to your general health as well, if there's any deficiencies as such. So would you mind if I ask you a couple of questions? And with infections, always ask them, so are you aware, have you been in contact with anyone that had any sort of viral bacterial infection? So again, it's more like a contact thing, isn't it? So ask them. And then that's what, like, I remember in 2018, they used to say that, yeah, my colleague, we were sharing the desk and she had a viral. So we have to ask her, well, did you had any bubbles, any vesicles? Okay. So that's how I would go in that case. But it's still aphthous, it's still aphthous. And it was recently quitting smoking. So that could have been the reason. And smokers, when they quit smoking, they do see ulceration more because smoking suppresses the immune system. And once they quit smoking, like without using nicotine replacement, the problem with that is this is an autoimmune condition. So the immune system goes back to normal, and that's why they see it more often. So if we put them on nicotine replacement options as part of quitting smoking, they will have less episodes of this, number one. And two, stress management. Again, stress, don't give solution. Ask them what would help them. If it's their exam, how do they generally go about with managing their stress? What is their coping mechanism for stress? And I'm sure you guys can relate to that. Oftentimes it's time management. I think we're all guilty of that, not managing time, doing last minute and the deadline, and that's what freaks out. So yeah, that's
Nazia,
basically this case. Yeah.
Is it required to give all the differential diagnosis like what's mentioned
No.
in TG? Start with the common and then, okay, so we don't need to go to that extent. It's just
trauma, aphthous, infection. That's it.
All right. Okay. Yeah.
Dr. Nazia,
19.
When they ask how will you differentiate between traumatic and aphthous, then what should we say?
The way it looks. So it's basically, let me see where it is. So the way we differentiate is this. In traumatic ulcer, you see that white halo around it, hyperkeratinized area. And also size does not matter. And it will be always next to where there's a sharp tooth or a cord. It can appear anywhere, not specific to keratinized, non-keratinized. And also it does not follow any pattern. You remove the source, it will go away. Now, when it comes to aphthous, and in aphthous, even trauma can trigger aphthous. But the problem with aphthous, do you see around it? It's red, inflamed. White, red around it, inflammation around it. And this middle lips, you can see how yellowish it is. And it always happens on non-keratinized area, which is like the cheeks, the tongue, right? Those area floor of the mouth, we tend to see it. And whether trauma was the source or it appeared, it will always follow that 7 to 10 days pattern. Regardless of what triggered it, it will follow that pattern. And on that note, I already have an aphthous in my mouth right now. So if this is something that just doesn't go away, it's unfortunately somebody that is genetically prone, they will always get it. But yes, with age, the episode gets less and less. It is something they have to live with it, manage their stress. If you guys find a solution to stress, please let me know as well. So I'll go to the next. Yep.
With the syphilis as a DD, we again go about it the same way, like asking if you had any contact with it, with anyone having any bacterial infection.
Don't go too much detail. Just say any. Yeah, just say any. So, have you been in contact, or do you know anyone around you that had any viral bacterial infection as well? Okay. But it's not a big deal. It's not the main assessment. It is an after-sales. So the case is on after-sales. It's built on stress. And they're checking how you're going to be having that motivational type of conversation around stress. Stress is major, huge in this case. Okay? Stress, don't compromise on stress. Connection of stress with afters and preventive advice for stress, this is extremely important in this case. Then we move on to that 11-year-old that came MIH, and an 11-year-old, they said that the boy, he saw a schoolman, a school gentleman, not a hospital. So that's new. Okay. School van, but the same thing, same photo sideways, same OPG given. And then the school van, they said the upper should be removed. Remember, not the lower. And in the exam, I want you to, so it's very subtle. You can't really see class 2 malocclusion clearly, but there was class 2 malocclusion in this case. And that was the reason for tooth removal. Now the upper, and they give you sideways, you can't see the palatal side. So there could be decay on the palatal side, who knows? So they wanted to know the same thing, that I want a second opinion. Do we need to remove his tooth? Why GA? Why do we need to remove the tooth for sensitivity? The son's name was Nick Henderson, so that was the name. And in terms of when he was little, he had ear infection many times. He didn't take antibiotic as such, but when he got 3 or 4, they did a procedure called grommets. The ear infection settled, but after that, he was put on long-term antibiotic. But what they want to test is your knowledge, because most of us, we think that antibiotic is the only thing that causes ear infection, MIH, but it's not the case. Even ear infection independently can cause MIH. So that's why they said he didn't take any antibiotic. He took antibiotic at the age of 5. So they're clearly saying, don't bring antibiotic into this. The cause was ear infection that caused this. So otherwise, it's pretty much the same. So it's just the school van they added in this one. And then comes the new denture case in the new set, in the green set. So again, the photo is more or less the same. It's very interesting. So different people gave me different versions. So I'm starting to see the versions now, which is very exciting. Sorry if I get excited about the OSCE. It's just that this is something, it's like pieces of puzzle. I put it together and, it's solving it. So in this case, 1727 was grade 2 MOBA, and patient lost all of the front teeth 25 years ago because of an accident. And the last dentist appointment was 7 years ago. And that's when it was relined, it was fixed. And after that, patient didn't go. So now, why did this patient come? Because patient lost his denture. The upper one, he lost it somewhere. And he had grandkids as well. And he said that I'm also concerned about angular colitis. My grandkids, they tell me that I look old. Do I look old? Don't. and he was like, look, initially I wasn't worried about it, but now they keep saying me, I am a bit conscious about the way I look. So 2 reasons was that. And again, angular colitis was not painful, but that wrinkly face was what was causing this patient worried. And medically, this patient was taking multivitamins. So do you see multivitamins was there? Blood test was done 6 months ago. They're like, don't drag me into that blood test, nutritional deficiency conversation. This is about fold. This is about reduced vertical dimension. Tell me about that. So clearly, they didn't want to get into the GP visit conversation. This version I'm talking about, where the denture was lost and his grandkids were calling him that he looks old. And then I'll talk about another version. And also, they said, what challenges would you face during denture fabrication? Discuss patient's concern, give all treatment options. Now, scenario said that the gums were flabby but the photo did not show flabby gums. So they wanted to know what options would you give to this patient. So we're starting to see, and attrition as well was very mild, not too much. And they wanted to know what options would you be giving to this patient. Again, management wise, I think we did discuss about it. I think there is a very good article. Let me bring it out. So there's two articles one is by BDJ and the other one.
Sorry, Nazia, regarding the challenges, is it just the flabby ridge, or should we talk also about the bone density on the anterior region as also a challenge? And what other
Overall
challenges do
challenge.
you think we have?
Oh, it's quite challenging fabricating anything in the front part of the mouth. I mean, if we talk about it, implants, if we talk about it, right? So the three main challenges that we have if somebody comes with a flabby ridge, right, is not only we have bone loss in general, also how much volume we have, and if we talk about implants in general, implants in maxilla, which has a higher prevalence of flabby ridge, are not as successful as in the mandible. We always know that implants. Why? Because of we have to go with the shorter implants because this area is highly vascular. We've got paranasal sinuses, then we have the air sinuses, poor volume, low density bone. So these always becomes quite challenging for us. So the three main approaches to management of fibrous flabby ridge is number one is conventional rehab that we always talk about, which is removing those teeth at the back and giving this patient a complete denture, but going with a mucocompressive technique, compression impression, which is again not easy to do it. I mean, if you can see, it's not easy to do it. So it's the way we take it. Now, if it's slightly flabby, you might still be able to give it a try, but it's if you don't get the impression correctly, it's just going to be a disaster. The second option that we have is implant supported rehab. They say it is supported for these patients, but I think the best way that we can go for this patient, of course, not surgical at this stage. So one of the options that we would recommend to this patient is, one option we can give you removable partial dentures, but these dentures are not going to be. I've got some photos here. So either we go with removable partial denture, but it will continue. Now, the removable partial denture that we can offer, I have another photo here. Sorry. There's a couple of ways we could look into it. I've got this is another BDJ article. So what they did was, this was a patient that had a lot of missing teeth, which this patient was given a flexible denture. Normally, flexible denture is good for smaller span, not bigger span. And then for this patient, then eventually the design they came up with was they combined flexible denture with metal. Was like a combination kind of technique that was given to the patient. But our patient really cannot go for even this one. It's not easy. And those two teeth at the back, were already grade 2 mobile. It's not going to hold it. So I would still give it as an option to the patient, but I'll tell them the difficulties because the clasp is going to keep bringing down. And you have to think about the biting forces. Remember, all lower teeth are natural. Now, a natural tooth against a denture is not a good idea. It's not a good idea because the biting force is very high. So one option would be we give them a complete denture, but a complete denture against natural teeth, disaster. Another option is we go with an overdenture, where overdenture implants are placed. It's slightly better than complete denture, but we know, again, pros and cons to that. Or third option is, as we said, we go with implant supported fixed bridge, where we don't put any implants in this area, where the flabby ridges are, or where if we bypass it and the implants are placed here, and then a bridge is built, because a bridge can can really withstand the biting forces from the natural teeth. All over are natural.
Dr. Nazia, just may I ask a few questions regarding the new updates here? First, if the patient lost his denture, should we discuss about interim denture till he take a decision, since he doesn't have a denture now?
Yeah, so with this one, interim would be our removable denture.
Okay, a second thing is you mentioned that he's conscious about how he looks and that his grandkids say that he looks old. Okay, so generally speaking, overdentures can have better support for lips since they are removable. We can add flanks there. Would in this case be our preferred option than the fixed one, since if we do bridges, we will not be able to have a good support for the lips as the overdenture? What do you think about that?
No, that's a good one. Now, and that's a good point you've raised, because we do need that support from here. Now, one of the question again, like I don't have the exact photo because when the patient said I had a bad accident, the thing that popped up in my mind was, if they had an accident, if the patient lost so many teeth, did that affect the bone as well, right? Which can happen
Yeah.
because of the fracture and injury. So we don't know about the status of that. And this patient said that those dentures were fine. Imagine 25 years, patient was wearing that removable denture, and then patient did not do any adjustment to that denture. So what happens? With time, patient said it started to started to disappear. So the bone resorption happened. And now that old version that the patient was saying, it was because of the angular colitis. Patient lost the denture, not wearing denture. So now wrinkles at the corner that happened. Right? So no, your point is fine. What you mentioned was fine. So you have to look at the situation. If you go with aesthetic, yes, overdentures, of course, it will give you that full support. Where you can place like 2 implants here and a overdenture sits. But complete denture is a disaster, not a good idea. Lower teeth are all natural. Or if we talk about from longevity in terms of function, then implant supported bridge can be a better option in terms of withstanding these binding forces. So both are like kind of implant we're talking about.
Dr. Nazia,
Yes.
what I got was he was here for RPD, and even I told him all the option. He said, no, I don't want to have any implants or any fixed one. I want the same one but a new one because it's been 25 years. I asked about the fit and everything. He said that, sorry about the background noise. He said that fit and everything is good. It's just that the denture is old, so it doesn't look good. So he wanted to keep those 1727 as well, but he said if could tell you the complication and in future you might need to take them out and all the forces with RPD, clasp and everything. I talk about that, and I said if I tell you that this might need to go out now, so it would be better if we can give you complete denture. He said, will that improve my like aesthetic part with the complete denture? And when I said that, is there any reason why you didn't go for a new denture, because we recommend new dentures every 5 years? He said, if I have come for every 5 years, would this have stopped like the bone loss, like the way he's having? So I said that whenever we make a new denture, so we make a new mold. It's according to the new bone height that you have at that moment. So it would giving you the better fit and everything. So of course it would help you with not as much as damaging bone loss like you have with just one single denture. So your bone loss has, but he was saying it's not wobbly, it's same. Like they just wanted to listen what you have to offer. If I say that I want to have the same like this denture but a new one, just because of the aesthetic, nothing changed, nothing new. And his concern was just the discoloration of the denture. And also he said, I am noticing folds around my mouth. So I mentioned that that's why you are having those fold because of the bone loss. And if we take the tooth out like 1727, then we will make a new denture according to your improved facial height. That will help with the folds as well. And I talked about implant and other, but he was like he didn't want me to go there much, so I just touched bit a little bit only.
All right. No, no, thanks for sharing that with us. And I think this OSCE is built on this article by DHSV, which is Treatment Planning for Multiple Tooth Replacement. And if you look at this article, it talks about that a patient can lose teeth because of many different, because of the disease, because of trauma. I think this should be on the portal as well. And they say as part of the established care pathway, they say acute phase, that we, if there was any pain, was there any sort of now in this case patient we had to look at what was the reason for that, if for this patient was aesthetic. And if we look at the they said that what considerations we always need to look at the age, what their expectations are. And then going back here, these were the different options we're talking about. So interim, or we talk it also transitional. So these ones basically are acrylic dentures that we give to the patient. And as we said that indicated where the client requires a functional prosthesis during a transition to definitive care, for example, and where you're not sure teeth that we're keeping or patient is just making decisions. And these RPDs can easily be converted to a complete denture as a transitional prosthesis as well. So I guess this is what they were looking for in the exam.
May I
Giving them a
add something, Dr. Nazia?
Yeah.
A friend of mine who had this case on the first time when it was Patricia, the examiner, she asked him a weird question. She asked him, how does the complete denture fit to my jaw? So it was vacuum. We all know the complete denture fit to the upper jaw like it's a vacuum seal. So now the doctor was mentioning, I think his RPD was fitting all 25 years because it was fitting to the tissues. It was like vacuum seal, but he's still losing a bone. That's why he lose his vertical dimension. I think that's what they want us to speak about.
Yeah, and the flabby ridges as well, so shifting. And I think the patient did say also that with my denture, before I lost it, my teeth started, and the visibility became poor. They started, like I couldn't see my teeth with passage of time.
Yes,
So
correct.
bone
That was the
loss.
first version. So I think the denture fits because of it fits the flappy ridge and it's vacuum seal, but he's still losing bone and that's why he has the reduced vertical dimension, cannot see his front teeth.
And in this case, what really strikes to me is why would they give us all natural teeth in the lower jaw? It's the occlusion, it's the forces, right? So you have to balance. So if you think clinically, so if the patient does not want to remove that tooth, it's fine. We start with interim RPDs, right? Or transitional RPDs. They give it to the patient, it's fine. But you warn them about the consequences as well. What will happen, right? And they say typically acrylic used as a vehicle to provide a temporary course of treatment, such as tissue treatment, restoration, or increase of vertical dimension. Right? We're doing that for this patient, if that's what the patient wants. But we also will guide the patient that, you have these teeth, and these teeth, natural teeth, have got much more biting force. And these dentures, they don't have a chance. And you gums that are flabby, you have these folds, these are all signs. So long term, how old was the patient, by the way? Any idea? I think one girl, she said 65. Was it 65 still or younger?
Yeah, doctor, my friend said that he was 66.
66. And the name was Green, right? Mr. Green.
He mentioned that his name was Mr. Smith, I think.
Mr. Smith? Really? Okay. Because the other girl, she said it was Green, Mr. Green.
But doctor, my friend mentioned that the patient came with the upper denture is not missing, but the main problem that is the teeth is severely worn, and there is a loss of vertical dimension, and the patient were concerned about the appearance.
Yeah, that was the other version. So
Yeah.
this is variation. So this denture being lost was one version. And then the other version, as you mentioned, that which came to many people was that patient came, the denture was not loose, and the fit was perfectly fine. It's just that the patient was worried about this tooth. I'm trying to find where that is there.
Yeah, but
Yeah.
the patient denied any history of grinding or anything like that, so, and yet the
Right.
patient is a smoker. So how can we address that?
So grinding is not always there, and we do see acrylic teeth with time. See, this for acrylic teeth biting against natural teeth. You would see the teeth being worn out. Now, also with these teeth, what was it made up of? Right. So there's three different types of Pontic. Sometimes porcelain used to be used back then. We don't know. But attrition wise, I've spoken to about 4 or 5 people. I don't know if Freya could also guide us on that. They said it was about like not that much attrition. You could see signs of attrition, which is age related. Sometimes you see. And this other version that the other girl got in the same batch, she said the examiner said, I can't see my teeth, and I'm mainly here for aesthetic issue. This one, the version, they did not lose the denture. No problem with the grandkids. But angular was there, of course, in this one as well.
Yes.
Yeah. So grinding, everybody has asked. There is no grinding. But this patient was not even wearing the denture at nighttime. Why would he have problems with grinding? Right? So grinding is not always the issue with attrition that we say. So I'm quite interested to see what material was these teeth made up of. I mean, normally mostly is acrylic though, but remember these teeth were made 25 years. These dentures were 25 years old. So fairly old. Where is my denture?
So in this case, the reason of shortening of the teeth is there is the bone resorption, not the teeth worn, right?
So teeth again depends on how much it is. From what they told me, it was not that worn out. It was teeny bit, like normal. But it was clearly mentioned flabby ridge on the scenario. So that's a good sign for us. But you need to check. Attrition was there. You need to check. And but how much? Like maybe teeny bit with attrition, but mainly it was the gums, the bones, because patient says I can't see my upper teeth. It was a major problem. Okay. So that's where we talk about here in that case. All right. So I think that's it.
Dr. Nazia, today both the cases come like the old combination syndrome and then this case. So is it possible that both room will be the diagnosis of a combination syndrome?
Today both came?
Yes, the previous one and this one as well.
So it's which
Yes, in the
variation?
same set.
Okay, I need to speak to those candidates.
And
Was
then,
it in this one? They've replaced hematoma?
yes, hematoma has been replaced with this case, and then in cluster 3, they brought the international student for cluster 3.
Dr.
Cluster
Nazia, and
3.
that was I was actually planning to ask you, in case of international student, how would they move it to cluster 3 and we don't even have diagnosis?
It's a cracked tooth syndrome. But I'm still interested to see. I'll find out more details about that. Because see, remember we had a discussion about it that a lot of you said that this diabetes case has been moved to cluster 3, and then I found out that it was the crown broken at the gum level. That case they added diabetes. It's so different to what you guys heard.
Okay.
That's my thing is a lot of things are rumor. A lot of things are misinformation. It's Chinese whisper. It's not the fact. So that's why I'm going back to candidates. After candidates, I'm talking to them directly. What did they see? So any information that I'm giving to you guys is 100% authentic. And I make sure I cross question. I speak to the candidates myself. And
Dr.
I'm pretty
Nazia?
sure with that international student, there's going to be rumors. I'll find out more about it though.
This is also true, like both denture case came for cluster
No,
2.
this definitely might have come for sure. I'll check. See then, with both cases that they came, now the combination syndrome, of course, is, and I think I'm just going to go back to this flow chart. So I think this is the new article from BDJ. Sorry, I just keep reading a lot. I love reading. And here in this is, how old is this one? I think it's 2018. It's not too old. And I think somewhere here they mention about that. Yeah, here, 2018. They said that each patient. So where did that combination syndrome came? It was because of Kelly. First, she described combination syndrome based on observation of 6 patients, and each patient wore a maxillary complete denture opposed by natural teeth with a distal extension mandibular partial denture. And she noted common presentations. The presentation that she included that she saw was alveolar ridge resorption of maxilla, enlargement of tuberosity, and resorption. But she said the term combination syndrome is less commonly used nowadays as features often do not present simultaneously. This is what I'm talking about. You see, the patterns that she described, that the idea evolved. Remember, we spoke about so many modifications now. So it's very hard now to so what we are also dealing is a variation. So what you're seeing is the early stages. And in that combination syndrome, it was well established, right? But what is the main thing? What is the main idea? When should you say it's a combination or not? It's this flabby ridge. This was the word given. If they would not give that word on the screen, I would not even bring combination in this case. Not at all. Right? So it says fiber replacement ridge is an area of mobile soft tissues affecting the maxillomandibular ridges. And it develops when a hyperplastic soft tissue replaces the alveolar bone and most commonly described as affecting the anterior maxillary alveolus. So that was happening in this patient. Just very initial stages.
So as I understand from you, Dr. Nazia, now that if they mention flabby ridge or we could see it, then we will mention about combination syndrome. Otherwise, we can just explain to the patient what we are seeing. Like we don't have to get into combination.
But they are saying, yeah. So this was probably in early stages of combination syndrome. Warn the patient. Remember, we had that denture stomatitis case as well. You couldn't see it on the screen, right? But there was combination syndrome in that as well. If you guys remember in that denture stomatitis, right? Do you see? Lower teeth, we can't see it. And I don't see any swollen gums here as such. The only way to figure out that it could be combination was because of these fractured teeth. You see? And we were like, oh, so I saw fractured teeth. So tell me about your lower teeth. Do you think like they're super erupted, they're coming out? And in this case, we're warning the patient, well, there's a potential for you to either have it or can develop combination syndrome, right? No flabby ridge given at all. Nothing given here, but yet combination is there, right? So they're testing your knowledge differently in each case, but it's still the same essence, same thing. All right, so I'm just the main thing you remember that now patient has flabby ridge. Now what will happen? Next step is these teeth patient will lose. After this, the patient will start losing the back teeth. This is how combination syndrome works. It starts from anterior maxilla, then it goes back, then as long as there are teeth, maxillary tuberosity will not get enlarged because these teeth are the ones that hold. The moment this patient is going to lose, the denture will now start causing suction. Now, right now, the denture is pulling the teeth down. Once the teeth are lost, then it will start pulling the posterior maxilla down, like a suction. That's what we call as tuberosity, enlarged. And when it starts pulling it down, these back teeth they have no chance. Patient will start losing these teeth. So this is just starting to develop. It is a combination syndrome, beginning of it. Okay.
Doctor, just one quick doubt, please.
What?
Nazia.
So let's do that. Yeah.
Yeah. Will these articles be uploaded, or
I'll
is
do
it?
it now, straight away, before I
Yeah.
forget.
Yes.
My
So
memory
you
is pretty
you've
bad.
shown 3 articles now, right?
Yes,
3 of
I've got
them.
it right now in front of me. I'm going to upload it straight away. These are
Okay.
very important articles, and I'll find the other one as well. Yeah, combination
Okay.
syndrome, they love it.
Just one more thing, Nasia. On this new case that's been mentioned, on the scenario it says flappy ridge, but on the picture we can't pick up the flappy ridge as such. We can't see any of that, but still we mentioned perhaps this could be a early stage because this is what we are seeing. Is that right?
Starting to just say they're starting
Starting.
to develop. Yeah.
Okay.
So how
Okay.
did we know? Maybe you might have palpated it. Maybe you might have felt like soft tissues around that area.
Okay. All right.
Dr. Nazia, may I ask a quick question to
Yes,
you?
Thank you.
Regarding the danger patient wants overseas and coming with the dental clearance, starting with the medication for osteoporosis situation, the new case,
Which case?
patient want dental clearance from the GP and starting with
Oh,
the
yeah, that the combination syndrome. Yep.
yeah, again combination syndrome. So in that situation, when the patient want to retain the lower anterior teeth, and we discussed that we can let them to be retained, and we can make them over denture, right?
We said depends on where those teeth are, strategic teeth.
Yes, yes.
Not
And
all
like
of them.
yes, like if it is a canine, we can prefer to leave them, right? But do you think that patient is coming for the clearance and there's a high chance that we will lose it soon because it's a grade 2 mobile and then we need to start with the medication and then patient is having more chance of bronch. So why we are not thinking
Examiner
about
really took a viva on that grade 2 mobility
yeah,
this week.
that is I understood, but now it would have been normal patient that is justifiable. But now patient is having starting with the medication for osteoporosis, and so we need to eliminate any near future extractions. And now these teeth are grade
Don't
mobile.
have to extract it. That's what I'm saying. You have to give option. Remember that clearance word is a trap. So clearance doesn't mean literal. So there's two words to clearance. One is literal word clearance, clear everything, remove everything. And the other one, clearance, is you making sure this patient is dentally fit,
Mm-hmm.
right? And that's the second one they're going for, making sure this patient is dentally fit. It is patient's body. It is the patient's right to make decisions, whatever they want. You can only give suggestions, right? So remember we discussed about it that for RPD, definitely was no chance we could use these two the way it is because it's like, pulling the tooth out with, a screwdriver. Like you can't do that. But the other option that we were giving to the patient was if you really are keen, we could use it as an abutment, as a, underneath the overdenture. But even with that, remember the clinical reasoning I mentioned they're looking for? The clinical reasoning was caries. The difference between keeping this tooth and implant, both will have periodontal, no doubt about it. But implant will not have caries while this tooth can have caries. And then remember we said it's not your problem, patient's problem. Ask the patient, do you think you can maintain this tooth?
Yeah, but we need to let the patient know that if we need to retain this, then and if we lose these tooth in year time or 2 year time, there's a high chance of getting bronch.
But for 4 years is fine. I mean, we've had many cases,
Sorry, I
right?
didn't.
And is under 4 years,
Okay,
4 years, if you look at TG, as long as there's no caries, no gum infection, they're low risk.
okay, okay. But
Right.
what
So
if
that's what I'm saying, that you have to be, they're testing your knowledge and you're like checking your flexibility. It's hard to tell, are they testing my knowledge or they're checking me like who I am as a person, like am I doctor centered or not?
Okay,
So this is where becomes critical. They are checking, would you acknowledge patient's wishes,
okay.
right? If they want to keep that tooth. So I will honor it and I'll say to the patient, look, it's forget about the future. Talk about now. If this patient lost so many teeth, I'll say, look, I'm happy for you to keep these teeth if you want, but with removal then just not possible, right? It will eventually pop out because the way it keeps pulling the tooth. Overdenture is an option. Yeah, can be done. These teeth canines are sitting at the right spot. We could use it. The only problem is maintenance. Would you could it? Remember I said This is part of leadership skill. Put the responsibility back. Don't do your work. Don't micromanage. Just say, can you look after these teeth? Can you ensure that these teeth will not have any decay? Because maybe if you didn't look after in a few years, we're going to lose these teeth. And the further you go with these medications, the higher risk of bronch.
Okay. What if they are starting with denosumab? We are not sure about it, which medication
Oh,
they are.
denosumab, believe me, a lot of GPs are not prescribing. My husband's a GP. They said they're phasing it out. So denosumab is never the first line. It's always tablets, unless the patient is really forgetting, unless there's some issues.
Okay.
Yeah, no, denosumab. And again, there's a lot more companies as well that have come out now. So no, I think there was a new research as well. I mean, my oncologist as well I had a discussion with her as well about denosumab. They said according to the new research, the efficacy of denosumab is not as good as other medications for osteoporosis. So they're kind of just chucking it away slowly, gradually.
Okay. Yeah, thank you so much.
Okay. All right, so I think we can just end the session. But what I'll do is I'll find out more. I'm on a hunt of getting to know more questions about the red set, and I'll find out more about this international student. I'm sure there's more to it. What do you guys hear? But yeah, I'll update you again next week. All right, thank you so much, everyone. Have a great night.